Everyone, this is Enrique Bakemeyer with Healthcare Business Insights, and I'd like to welcome you to today's Thought Leadership webinar hosted by PMMC, Denial Management Essentials, the and reporting tools you need to increase revenue. Here on slide 2, you will have the opportunity to ask questions during the webinar by typing them in the space provided in the open Q&A field on the right-hand side of the screen. We will take a couple of brief pauses to field questions on slides 17 and 29 and at the conclusion of the webinar. If you need assistance at any point during the webinar, please call our client engagement team at 888-700-5223 for personal attention. Today's program is being recorded, and registered attendees will receive a copy of the presentation by email in the next couple of days. The presentation is also available right now on the AI web portal under the Research tab in the Conferences category. Here are learning objectives for today's session. The key denials-related metrics that healthcare organizations must track, review most effective methods for reporting denials data, as well as what questions those reports answer, explain how different reports are used by different revenue cycle stakeholders to identify denial trends and make strategic adjustments. Before I turn it over to our speaker, let's spend a few minutes reviewing some HBI research on the subject of today's webinar and also launch today's first in-conference poll. The quiz is, which primary root cause of denials are you most focused on today at your organization? The answers are registration eligibility, claim data, authorization pre-certification, documentation requested, covered, metacoding medical necessity, upness of care, or other. Again, that question is, which primary root cause of denials are you most focused on today at your organization? Answers are there, as you can see. Now, this is a perennially hot topic for HBI members. The last few years, when we've asked on our annual revenue cycle thesis survey about the top issues your organizations are facing, denial management is consistently at or near the top of the list. It's a topic that we at HBI have focused on for quite some time, and in fact, the first report of last year's Best Practice series was all about denial management. That report is called Addressing Root Causes Through Analytics and a Team-Based Culture. If you're familiar with it, we encourage you to download it from our members-only portal. One chapter of that report is devoted to the topic of today's webinar, with analytics and translating data about denials into action. In order to do that, more and more organizations are using dashboard reports to pinpoint denial root causes and analyze trends. When we most recently asked about dashboards on the survey, a majority of respondents said that they were using dashboards to drill down to denial root causes and categories all or a majority of the time. Our shows that organizations have had the most success using dashboard reports that include denial origins, such as by payer, patient type, or service area, and the reports that allow users to pinpoint root causes and view trends over time, and visualization tools so team members can quickly spot improvement opportunities and take action. Another practice that shows up consistently in our research is the use of multidisciplinary denial management task forces to review data and develop solutions. The composition of these task forces varies somewhat between organizations, but generally they take into account clinical and administrative perspectives on how to address common denial root causes. Again, more information on how to put the ideas that you will be taking away from today's session into action, please see our report Addressing Root Causes Through Analytics and a Team-Based Culture online now. A collection of resources online in our implementation portfolio, Enhancing Denial Prevention and Management. In that portfolio, we have several resources that can help inform your denial management efforts. In addition to best practice case studies, here you will also find job descriptions, previous virtual conference recordings, sample appeal letters, and more. On this slide, we've highlighted some helpful tools that we have created based on member requests, a denial management project charter, an article from our analytics journal about denial management trends, a narrative study we did of 4 organizations' centralized denial management structures. As a way of segueing into today's presentation, let's establish some context about the current industry environment and how denial management can address the challenges we're all facing. Just a couple weeks ago, there was an article in Forbes headlined, "Why Major Hospitals Are Losing Money by the Millions" by Dr. Robert Pearl. Viewed the big picture challenges organizations are facing and called attention to the fact that some of the top healthcare providers in the country have seen their margins drop significantly or have experienced outright losses. The article includes the perspectives of some healthcare CEOs, which we've reproduced a couple of quotes here, that explain the situation, namely revenues are flat, expenses are higher, driven in part by a sicker patient population. All the pressures that organizations are experiencing are due to factors that are not necessarily in the control of healthcare providers, but denial management is something that organizations can tackle as a way of mitigating these declining margins. And without further ado, I'd like to introduce our speaker for today's webinar, Greg Kay of PMMC. Greg has over 20 years of experience in the revenue cycle world and also has been experienced, as you can see from his bio, in multi-site operations management and care negotiation that is, from a healthcare provider's vantage point. Greg,
Thank you, Enrique. We do appreciate the opportunity to work with Healthcare Business Insight and present today's session. Continuing to move through transformative changes, and there is constant pressure to improve. Today, we will be reviewing some key metrics and analytical reporting approaches to help improving your denial management process. We'll review some basic process principles that can be applied to denial management. Then we'll review some various reporting templates with categorization and drill down options for deeper analysis. While patient denials, as we know, denials often start due to a breakdown in various areas of the revenue cycle. Link back to people, processes, technology, and/or data. As an example, medical necessity denials be due to any one or combination of these items. Coding could be a staffing issue, in other words, are the right people in the right place, or if additional training is needed, there could be a process breakdown. As where denials are occurring, at the end of the day, the prioritization process should start with an understanding of the impact on your revenue. Denials often occur at a rate of 10 to 15% of all claims. And after the rebilling and appeal process, this often to a 2 to 3% bottom line impact. Good news is a high percentage, according to FMA, 67% of denials are appealable, and a significant amount, often reported 70% or more, are preventable. It's also important to note that the average cost to a denied claim is $25. Relates to prevention, organizations still view denials as a back office task. While constantly being published that registration and eligibility issues are typically the highest percentage of denials, more than 30%. This area is one key place where proactive improvements can assist in preventing those denials. Governments today also view denials as needing to be handled as an insurance follow-up item, when there are clinical factors that may need to be addressed as well. Methody, requests for medical documentation, medical claim is also 20% of the overall denial rate. The recovery of the underpayment can be viewed as a prevention step as well. In other words, not letting the underpaid amount remain underpaid. Process, as defined by Six Sigma, is defined over 5 steps or levels. We have a denial management process with the first levels in place. Sigma, that means at level 3, a test that is fully deployed in place. Step level 1, accountability, is the baseline data gathering and workflow stage. The starting point and really begins with the categorization of denials. It includes cascodes to denial reasons, categories such as registration, authorization, pre-cert, medical necessity, missing data, medical documents required, court benefit. Some of the ones that we listed in open polling question. Now, flow under the accountability area. This is on into routing of denials, user assignment, work list, and accessing the detailed denial data. The component may be in place at your organization through your patient accounting system, through spreadsheets, through denial management or contract management tools, 835 data aggregation tools. When we start to level 2 and reporting, this is access to the data. There should be standard reports providing a baseline operational insight for accountability. Reporting tools would include things like denials by payer, denials by category, denials by code. Moving metrics, we move to prevention. And their goal is the elimination or resolution of the issue. This including systems or process changes, such as a denial category or a denial code report, to drive changes in the EMR or your system. An example would be a medical necessity report that may identify the need for front-end diagnosis edits, claim edit software that be used to correct variable registration numbers. With registration and eligibility denials, with that being the highest percentage of all denials, eligibility verification should occur multiple times, whether it's 3 to the service and before submission. This type of proactive step or measurements really are designed to reduce those. Now, kind of reporting at level 2, analytics at level 3 are the catalyst or drivers for process improvement or prevention. Prevention is described as the middle level on the maturity matrix, but correcting or reversing the denial is really what creates more immediate cash flow. The recovery denial is a component of this level. If payer payment rules, if coding requirements, patient stayed with the same payer with the same benefit plan forever, prevention would likely mean completely eliminating the problem. Ultimately, these items are not static, just like our world revenue cycle is not static. It's very dynamic, which means we may not know what to prevent until something of value is denied. Thus, the goal, in our view, is a part of the prevention step in that we still want to be paid for provided service. Another thing about analytics is the concept of root cause analysis. Provides quantitative insight, whereas analytics should both a quantitative as well as a qualitative assessment. Some examples would be looking at most common denials, including how much impact are the denials having to net patient revenue and the underlying reason for those denials. The two, being report and analytics, really work together as drivers but that helps take you to the next level is to incorporate benchmarks and a constant feedback loop, and what separates analytics from reporting. To incorporate analytics with reporting to improve the prevention level, it's important to note that not all denials are equal. Historically, denials have been viewed or grouped in two categories, often referred to as soft denials, which is being temporary, pending additional documentation or action such as a rebill, and denials where an appeal process is required. Also be viewed as preventable denials, all result from actions, inaction on the part of the provider. And preventable denials are 90% of all denials, and these are associated with elective procedures. Often require additional medical or clinical clarification, and technical denials often require additional documentation, such as clarification, medical records, or the bill. Often occurring at a rate of 10 to 15% of all claims, and again, billing and appeal process, it translating to 2 to 3% of the bottom line. This type of error rate is likely unsustainable. To accomplish improvement, measures are critical, especially against benchmarks, because measurements, we don't know if improvements are being made, and learn or know what truly is meaningful. Denial analytics should be built on a station or concept, if you will, around performance measurements. And it's aggregating 835 transaction sets, but really broadly, denial data analytics should include additional information, such as the expected reimbursement, to truly understand the net impact on your patient revenue. Hospitals today do report denials in some areas using charges. This because that's potentially when total charges are being denied. It's a reporting mechanism, but it often prevents you from really effectively prioritizing your denials and cash in the door. Just because a Medicare account has a $10,000 denial charge doesn't mean it's more valuable than a Blue Cross Shield account with a $1,000 denied charge. Performance is a continuous process. It involves checking the performance against standard or a target. Keep an external standard is not available or doesn't seem applicable to you or your organization. An analysis of your historical data can be used to establish your target. The point is to establish your target. To remember that with the volume of data associated with denials, it's meant to use the 80-20 rule. The key is know the 20 to 25 denial codes that represent 80+% organizations' denials. Keep in mind a thought by the management by exception guru Frederick Taylor may concentrate on only exceptional deviations in trying to correct every deviation. In other words, are you trying to control everything if they end up controlling nothing at all? With your denial process, keep in mind that there are multitudes of benchmarks and KPIs out different indicating sources such as HBI, HFMA, AMA, is to determine the ones that work for you. The key components of measure, track, and trend. As the saying goes, have a plan, but also change the plan. will help you know when to change and adjust your plan. So denial rate of 10 to 50% occurring with all claims, and again, rebilling and the appeal process, it's translating to 2 to 3% of the bottom line impact, does not continue to be a challenge. One way to move the process forward to that next level is data visualization. It's an ideal way to move denial management analytics in that it incorporates both performance measurements and its users to quickly view and understand a vast amount of data, not data, but information. As industry insight, Drillabilities provide a deeper analysis of various components that drive the metrics, again referred to as root cause analytics. The visualization, a manager can view the latest figures in current overall account activity and denial volume and respond quickly to a potential growing issue. As a static denial report, inform a manager that the overall denial rate with a payer is up for a particular month. How it won't inform them necessarily on what's up. The data with drill down ability allows users to quickly assess and determine the root cause, allow staff to be adjusted to a volume increase or decrease mid-month to a problem. Analysis really requires some baseline principles, including with the data capture process. With the volume data that we're looking at when we consider denial management, it is critical to have accurate and deep underlying data. Summary used, but find that summary data will limit your ability to drill down to essentially the real insightful level. Besides, we'll review various report templates with categorization and drill down options. This was an insight that I recently found from a survey by the Aberdeen Group. It measures in organizations that use visual data discovery tools are likely to find relevant information compared to those who rely on traditional management dashboards and reports. In that same study, the managers at organizations that use visual data analytic tools are 3 times more likely to comment and share a report or a chart. They're 3 times more likely to comment and share a report or chart, which meant this facilitates that collaborative organizational approach when dealing with denial management improvement. Enrique, polling question.
Thank you, Mac. We will take a break right here for our first Q&A break and our next poll. But first, we'll share the results of our first in-conference poll. As a reminder, that question was, which primary root cause of denials are you most focused on today at your organization? The answers were 4% said appropriateness of care, 4% said service not covered, 9% said medical documentation requested. And the top 3 were 5% said registration and eligibility, and 29% both said authorization/pre-certification, and also 29% said medical coding/medical necessity. Now we'll go to our second in-conference poll. What type of analysis generally gives your organization the most actionable insight? The answers here are by payer, by denial category, by net revenue, by or other. Again, the question was, which type of analysis generally gives your organization the most actionable insight? And the answers you can see on your screen. First question, Greg, that we have here in the queue. Are there any areas of low-hanging fruit, so to speak, as far as process improvements that will prevent the most common sources of denials.
I am, Enrique.
All righty.
I had to remember to unmute.
Very good.
So thank you. So I'll address two areas that were the 2 or 3 highest areas. The first is registration errors and ability. Mentioned a moment ago, organizations should look to incorporate multiple eligibility and registration checks as patients do move from plan to plan or insurance coverage. It's important that we check ability both at time of scheduling, so that we have an opportunity to follow up with the payer or with the patient to ensure they are covered. Checking 2 to 3 days prior to the scheduled procedure, and also checking prior to claim submission. That if we do find the patient is no longer covered by that particular plan, we can take the corrective actions in a proactive way. The other is with authorization. Over the last number of years, there have been, I think, more of a general understanding between providers and payers that certain services were typically covered, and authorization wasn't always requested. I think new and reimbursement gets tighter on both sides for payer and providers. We're going to see more of an adversarial relationship kind of growing, if you will. There's some trend there that we're seeing with payer rules changing that will be moving our industry more towards checking and wiring and receiving authorization for all services. And that's something that we'll be looking to move towards as an industry, whether that be through a manual check or through an automated check, getting that pre-authorization up front before, especially with any elective procedure, should always be the rule.
Here's a question that I think refers to some of your experience, particularly in contracting. What do we do with our payer contracts to define audit parameters?
I'm a little lost when they are referring to define audit parameters.
Like, deadlines and ability to perform audits.
I think it comes back to with any contract, everything should be clearly defined and spelled out. As payers update their payer policies, their payment policies, that would be one area that you should always require language that those payment policies are provided to you. Any type of timely filing rules, any type of follow-up, any type of payment identification recovery should also be clearly defined in terms of the parameters that you have and what you'll be working with. Always back to the contract is really your baseline for any type of audit or collection process.
All right, we'll take one more here before moving on. This question here is about another contracting, some-related question. If a relatively minor payer is a major source of denials, at what point should we consider no longer contracting with them?
Individual facility by facility call, but as a general rule, one of the trends that we are seeing is many organizations over the last number of years have minor payer contracts continue to follow the evergreen term in the agreements and just allow those percent charge, because they were minor payers, just to roll forward. And all those are older in nature. Many of the terms that we see today in terms of denials are defined in those older contracts. Many of those minor payers do deny more frequently. So while you're getting a percent of charge, that doesn't necessarily mean you're getting a percent of all charges. If payers do have ability to bundle codes, deny, partial deny services. You definitely need to look at those minor payers as opportunities to assess from a contract renegotiation relationship.
That sounds good, Greg. Okay, at this point, we'll take a pause here on the questions. We'll move back to the regular presentation. As a reminder, we will take questions again on slide 29. So the audience, please continue to put questions in the Q&A field. Greg, I've turned the presentation back over to you.
Great, thanks, Enrique. We're going to be looking at our actual report examples. In today's presentation, we've grouped different reports into categories, if you will. The first set of reports we're going to be looking at are what we refer to as payer denial analytic reports. Are going to be addressing key questions from a mid-management level, being directors, managers, managed care, patient accounting. And here are some key questions that the reports would look to. And as we noted, these slides are available, and our intent here is to provide you with some insight into different report templates that you may be able to build or to leverage with your internal processes. So this report that we're looking at is a good example of a comparative analytic report. It provides a table and a chart, unique data sets, and that appears with the denials. An analytic model allows the user to easily drill down to the denial category, the denial code, and in this particular case, the physician. As you notice this particular report, your eyes typically would migrate to the pie chart on screen. We then our attention focuses to the highest pieces of the pie in this particular pie chart, and that's Blue Cross, Blue Shield, and the health plan star. Data helps us get a meaningful understanding and quick answers. But as we start looking at the data visualization reports, please keep the important visualization principles. Again, have accurate, detailed data, and know what you want at the roll-up and drill-down level. We group denials by payer with the ability to drill down to the category, the code, and physician level. Had revenue amount be a good example of an enhancement to a denial management report where we're looking at lines or claims and charges. This example of a comparative analysis report, it provides a graph presentation instead of a pie chart. This particular table focuses in on redenial rates by year. This red and green to make it easier for identifying patterns. In doing redenial rates, you start to be able to see we're getting denied multiple times for the account. By diving deeper into this, you can begin to prioritize your work based upon what has been successfully overturned in the past. The analytical model allows users to easily drill down to denial code category, the denial code, and into the physician level. There's another comparative analytical report. It will tables of the top denial by volume. By grouping in various ways, again, the goal is to easily spot trends at a glance. In this, we see that reason code 97 whittled into another service, and 13, payment was provided in another previous payment, are the two largest areas. In the table, we so quickly see that health plan and Blue Cross Shield are the two payers respectively. And this such as, why is Blue Cross at 1 million when the others are at virtually 0. This could indicate I've got a problem with Blue Cross Blue Shield, or maybe I have a problem in my posting department. The next reports we're going to be looking at is grouping denials in categories. Addressing the same audience of directors, managers, managed care, and accounting. And here are some questions that categorizations or categories would provide insight with. One applies denial data in a specific fashion. Another start denials by category and drill down to the payer, into the denial code, and then to a lower level. In this, we would to start with incorrect billing data with the biggest impact. By then, we would be able to see specifics around what payers are denying and specifics around a denial. In other words, what service is being denied? Is it for a missing PA indicator, invalid units, invalid modifiers, etc. Denials on a month-over-month basis, we can quickly tell whether or not you can address the root problem as of incorrect billing or denial at the claim level. Also an indication of where we see trends going up or trend down. Now, first report with a graphical presentation and visualization tools, you quickly become accustomed to it, and while helpful to have visualization, it's not always necessary or needed. If your denial category or reason code you get, it can easily just in the details. For example, we found that it's helpful to group the top 2 or 3 reason codes for each category. That we're able to get a one-page snapshot that tells us where our leverage points are with our denials over this 5-month period. For example, if we simply improve the registration process and capture the full insurance information, we potentially prevent or reduce the 1.7 million from the pre-category, as the payer could not be identified, the payer with the initial claim. Another is 1.92 million in coordination of benefit denials in the incorrect billing data category. For the prior slides, been a little bit too simplistic. They may have a lot more information on a slide view. For us, this particular view may be too overwhelming. Again, depending on the user, your preference, the data visualization allows you to decide what you want to see on a report. This example does incorporate multiple components into a presentation screen. We see that 2% of denied claims have been appealed or worked. From a standpoint, this percent represents nearly 20% of denied net patient revenue that's been recovered and percent of denied charge. The below line graph highlight the correlation between the percent of reimbursement worked and the percent reimbursement collected by category. You decide how you want to see your people are a part of the process, either prevent or in the card denials actually recovering underpayments. See goals or metrics for staff in terms of audit follow-up team. The chart in the bar graph, we can see a high correlation between top 4 performers. There are slices of pie. You can also see the number of accounts that the key performers performance be one of the key performer drivers, if you will, in assess. But an analysis of the data really shows that when it relates to our net recovery results, being our dark line here, we can, while Patrick and Tab are working half the number of accounts, they're driving the net revenue performance for the team. We can also, while Dana is working a lot of accounts and a lot of charges, there's little impact on net revenue. Again, great example of how you can analyze the data depending on how you want to see it, to on what your team is doing and where the roots are coming from. Enrique, question.
We do. We'll pause for our second Q&A break. First, I'll share the results of our last in-conference poll. As a reminder, that question was, which type of analysis generally gives your organization the most actionable insight? 2% said by charges, 24% said by payer, and the vast majority, 74%, said by denial category. And now we'll launch our final in-conference poll. What is your organization's biggest challenge around denial management? The answers are accountability, reporting, prevention, ethics, or artificial intelligence. Again, the question is, what is your organization's biggest challenge around denial management? Is accountability, reporting, prevention, analytics, or artificial intelligence? I'll take a couple questions right here. First of all, just one quick clarification. Could you please clarify what redenial means? Is that something denied after it has been appealed?
That would be where you have appealed it once and the peer denied it a second time, and you may go through the process of appealing it again with the same information or more likely additional information to your success.
Sounds good. Here we got one here. Earlier in the presentation, you mentioned verifying the insurance several times. Key time being before the claim goes out. For systems that do this, would it be the business office or patient access that re-verifies before the claim goes out?
That depends on your organization. We've seen it done different ways. It would obviously be an area that you may want to look at as a process improvement. If you're not making headway today with the way the process is set up, your front-end team is responsible for doing it today. You may want to shift some of that to your back office team so there is, especially for elective procedures, you want to do another check just prior to claim submission. Check may be done by another team other than the front-end staff.
All right. There's another one. This may be coming, but see only remit or CARC codes reporting. Never look at the remark code. For example, the A is very generic. The remark code should be more specific and more helpful.
From our organization standpoint, that is coming. So with the reports that we're using, these are reports that are from our team. You can pull data. As I mentioned, one of the core principles as it relates to data visualization is to always start with the lowest level of detailed data that you have access to. So depending on what you want to bring into the system will help drive how that data is presented, whether it's at whatever level of detail you're looking to capture, your systems are capturing the data.
And we'll just take one more here at this break. Here's one. Is there a normal fluctuation in denial levels? And if so, what may be a possible cause if they go too much, or if they drop too much, or if they rise too much month to month?
Would be after Medicare enrollment. they significantly go up. But it's the whole premise behind needing data visualization and managing your denials beyond just the accountability level of having a workflow tool. Work denials, you should be moving up the denial maturity matrix curve, integrating both reporting, then prevention, then moving on into the we're discussing today, and that's the analytics, to begin looking for the trends and analyzing it over time, that you identify what's really going on with your payers and in your particular marketplace.
As a reminder, we'll take one last Q&A at the end of the presentation. At this time, Greg, I will return control back to you.
Great, Enrique. So then we'll be looking at are more the executive level summary health denial reports. Here we'll focus more on the C-suite and questions that the suite would be looking to raise or looking for answers with. Now, at C-suite level, they're typically looking at broader trend lines, and this example looks at total denials month over month. You can quickly see the November 2016 spike, and this to the holidays or a rule change that typically occur in October. You can also see that we not see a spike in January when we see Medicare outpatient rule changes. So the reports do provide the insight, the drill capability to the payer level, then the category, or even to the code level, allows us to more quickly understand the issue and able to quickly point to what questions you raised. That ties back to the last poll question, really knowing based on your data what questions should we be looking for when we do see these dips or peaks in the process. Report group denied charges with the allowable and the payment by month. Recurring denials in conjunction with net revenue and collections can be insightful. Denied charges and associated net patient revenue are fairly flat. As an example, with January versus February, the question is, why are my payments down? Similar with a comparison of July versus June, patient revenue are up, but my collections are down. After this, I can begin to question, what are we dealing, what are we collecting, not collecting, which is driving our denials and collections, and not overturning. This will identify which denial categories, payer codes, or worth time with limited resources as I try to really focus on the 80% of the recovery based upon the 20% of the codes that need to be working. Highlights a spike in volume with pre-reg in July. Spike in the dollar value comes from claim level denial issues. The two could be related, and the coordination of benefits may impact the claim level denials. We will ask questions through a graphical presentation like this. Incorporate denials into your analytical process should not be limited to just office prevention and office recovery. The analytics should be incorporated into your prospective contract modeling and negotiation process as well. With a denial rate that hits most organizations' bottom line in the 3% area, and in this particular model, it was a 3.8% hit, it's charged not to be incorporated into your by-side payer reimbursement modeling. So we're doing what-if scenarios in the negotiation process, or to the prior question of what do we do with our small to size payers, this type of modeling that you should be doing and really analyzing not only what your net revenue is based on your service mix and your charges, but what is the impact on denials with net revenue. Questions have to do with really drilling all the way down to position level. Now, for directors or managers that are associated with physicians, these that slides would particularly address. A way to look at denials by physician. Even dealing with professional charges, there may be a few physicians or surgeons that are doing many of your denials. Could be their procedure, order habits, or the items that they're using in the OR. It's they say they just have to do their way. Again, this is just another way of digging into the data at a deeper level for root cause analysis to identify the true outliers with your goals. And in this example, this healthcare provider was able to make significant reductions with denials with dark blue line physician. The name changed to protect both the innocent and the guilty. March, but see, there was a subsequent spike with physicians in that June to July time frame. Monitoring these over a month-over-month basis, again, helps ensure that you're printing denials and looking at denials different ways. Probably something that you would do on a daily basis, but obviously from a month-to-month or looking at this on a quarterly basis would give you some insight as to where to go to help that root cause analysis. Another important look at denials is at the service or CPT code level. And tying into one of the questions, having the detailed data allows you to go to the lowest level of analysis. In this case, it's by procedure and by physician. While these are necessarily the most lucrative denials as a whole, they can often lead to some of the easiest to produce both process improvement as cash prevention or pickup. Simply billing habits, such as a modifier to prevent denials, it could provide a true quick net revenue gain for your organization. Enrique, thank you for the opportunity to present today.
Greg, and at this time, we will finish up with our final Q&A session. Before we do that, here are the results of the last in-conference poll. The question was, what is your organization's biggest challenge around denial management? 30% said that it was accountability in the denial workflow, 10% said reporting, 50% said prevention, 10% said analytics, and 2% said artificial intelligence. And we just have a couple of questions here, seem to be focused on the physician side of things, since we just were covering that. What are some key ways for getting physicians to buy into denial prevention strategies?
The absolute most important step is to give them the data. Physicians typically respond to data. If you approach physicians with how you feel, it will be there. If you give them statistics, especially bubble graphs, and where they fall amongst their peers, you will quickly gain a loyal follower to your physicians.
And so we have one last one here then on the topic. How involved should physicians be in appealing denials and implementing denial prevention efforts?
organizations as a best practice, you should have someone designated on your staff as the physician liaison that can communicate or write correspondences to the payer physician liaison. That way, if you're doing a medical director to a medical director level, you're probably going to have more success peer-to-peer appeal than doing it otherwise.
And since we have no more questions in the queue, I think we'll leave it there. So thank you very much, Greg, and thank you all for attending today's Thought Leadership webinar hosted by PMMC, Denial Management Essentials, the metrics and reporting tools you need to increase revenue. Great rest of the week, everyone, and a happy Thanksgiving as well.